ever feel unsure how to describe what you've seen on an ultrasound, worried you'll sound too vague, but also afraid of overstating your skills? You are not alone. Ultrasound can feel intimidating. You've done the scan, but when it comes to reporting, you find yourself second guessing everything. Hello, I'm Dr. Camilla Edwards, veterinary surgeon with a passion for helping first opinion vets feel confident with ultrasound. This month we're doing something a little bit different. We're taking you on a sneak peek inside FOVU Club. This is my online community where vets learn to scan with structure, practice and feedback, which always leads to confidence. Inside the club, each month we focus on one theme. October is all about the liver. Members get a detailed how to scan video with 3D anatomy and probe hand positions, a pathology and update session, real first opinion cases, and a live Ask Me Anything session where I give you feedback on your scans. And now we've added a brand new feature, Speeds. Speeds is a simple framework that helps you break down your scans step by step so you can truly assess what you're seeing and write ultrasound reports with clarity and confidence. In this video, you will see Speeds in action applied to the liver. By the end, you'll know exactly how to describe a normal liver in a structured way, and you'll never feel stuck writing your report again. So let's dive straight in. Hello and welcome to this edition of Speeds. This month we'll be focusing on the liver. So we'll start with our first letter S, which stands for size and shape, and we'll start with size. So how can we judge the size of the liver, and what does it mean if it's too big or too small? So when we're assessing the liver size, we need to be thinking about our anatomical landmarks. So hepatomegaly is judged when we can see the caudal margin of the liver becomes rounded on ultrasound, or if it extends caudally beyond the costal arch. Microhepatica is slightly more challenging to identify, but can be suspected when the liver appears small with increased diaphragmatic contact. Maybe a large gallbladder appears to take up more room than the liver itself. You need to always interpret these alongside the whole clinical picture. So looking at that costal arch, does the liver extend caudally beyond the ribs? The caudal margin, is it sharp, like normal, or is it rounded? That could indicate hepatomegaly. And if the liver is very far cranial, then we need to judge whether there's microhepatica. We also need to think if it's a large dog, then their livers can be quite far cranial. So my top tip is when we're looking in right lateral recumbency, viewing the liver in a longitudinal plane, when we fan upwards away from the table, we can see the liver in the near field and the stomach in the far field. And this is an excellent point for judging whether the caudal edge is sharp or rounded. So let's look at a video on how to scan the liver, and you can see points where we might be judging hepatomegaly. So we want to feel with our fingers behind the xiphisternum here, and we want to just push our hand into the abdomen. We're cutting through in a longitudinal or sagittal plane. And we really want to, rather than push cranially, we want to push with our hand in towards the abdomen. This means that the probe isn't touching bone, which is extremely uncomfortable for the animal. So we want to optimize our image here. So I'm going to increase my depth so I can see that the diaphragm, this hyperechoic line, is fully in the image. And we can see it rounding off here. So we've really got the cranial part of the liver here, which is great. We can also see the gallbladder here. Got a slight artifact coming off one of the lobes of the liver. Once we've got this cranial view, I'll just adjust my focus zone as well. We can fan all the way down, keeping that cranial view as we go. Fan all the way up until the liver disappears. And then we want to get the caudal view. So now, rather than focusing on keeping this cranial corner in, we want to focus on getting this caudal corner in. So we bring the tail of the probe out, so we're rocking the probe. That means we've got the stomach here, we can see the caudal line of the liver down the centre of our image. We fan all the way up. This is a really good point to see, look out for hepatomegaly. If we've got a pointed liver like here, over the top of our stomach, that's usually a good sign that it's a normal sized liver. If it's rounded, then we're more concerned about hepatomegaly. Right, let's continue fanning up until the liver disappears, and then fan down again until the liver disappears. And we fan through the gallbladder there. You can see that here. Okay, I'm going to rotate my probe and just again pushing in towards the abdomen rather than cranially. We now can see that the diaphragm is much more horizontal. This is all liver parenchyma here. And then we're going to fan cranially, and then we can see the gallbladder again there on the right hand side of the body, left hand side of the screen. We fan caudally until the liver disappears. So this is an example of a liver that was enlarged, and this is the point where we're looking in the near field, close to the stomach. We've just reduced our depth so that we're really focused on this area and we can really make a clear judgment. So we can see the liver here is quite rounded. It's also distorted in its shape. So this is telling us that there is hepatomegaly present in this case. So let's move on to shape and what we're looking for when it comes to the liver. When it comes to the shape of the liver, the overall shape of the liver should be smooth and uniform. In a normal scan, the liver maintains consistent contours without bulges like we saw in that previous video as well. No lobulation. We can't distinguish the different lobes of the liver on normal ultrasound unless something is pushing them apart like fluid or any sort of distortion of the shape. So these changes often accompany hepatomegaly like we saw in that just previous case, but it can also be focal lesions that are altering the shape of the liver. But these are, again, best interpreted alongside the size, edge and position of the liver. So contour should be smooth, no irregularities around the edge, rounded versus sharp margins, again thinking about hepatomegaly and looking for focal distortion. So my top tip here is that you won't normally see individual liver lobes unless ascites is separating them. So focus instead on the overall contour. Sharp caudal edges are normal, rounded margins or focal bulges suggest enlargement or possibly a focal tumour. So let's take a look at this liver with its distorted shape. So we can see that there's definitely ascites pushing those lobes away. This overall looks very large and rounded, distorted in its shape up here. So those are the type of things that we are looking for when it comes to shape. Moving on to our next letter, P stands for position. So we'd normally expect the liver to be in the cranial abdomen with contact with the diaphragm, which often shows up as bright white. The bright white is actually, in fact, the gas that's being reflected in the lungs. And so it should just sit just caudal to that. And it should all be within the area of the costal arch. It should maintain contact with the diaphragm, so there shouldn't be anything between it, such as ascites. There shouldn't be anything pushing it caudally, And if we are thinking about diaphragmatic hernias, then it shouldn't be being moved cranially either. So abnormal position is not particularly common, but might occur with a fusion, diaphragmatic hernia, or space-occupying lesions. So we're expecting liver in the cranial abdomen, beneath the costal arch, caudal to the diaphragm. Normal contact with diaphragm and the cranial abdominal wall, and we're watching for displacement. So one tip I've got here is don't mistake a break in the diaphragm for a hernia. This is often seen where the caudal vena cava crosses the diaphragm, but also as a refraction artifact when the sound beam hits the diaphragm at just the wrong angle. So let's take a look. So we might have fluid. Here we've got the diaphragm, we've got liver being pushed away from the diaphragm wall. It's lost contact with the diaphragm wall here, so it's being pushed caudally. And then we've got a case where we've got a diaphragmatic hernia, and we're seeing liver in the chest there when we're scanning. We're seeing some lungs, gas in the lungs, and then liver just on the other side there. Moving on to our first E, which stands for echogenicity and echotexture. When it comes to echogenicity, we're thinking about whether something's hyperechoic, hypoechoic, isoechoic, anechoic, and these are all by comparison. So the liver should be slightly less hyperechoic than the spleen, but more hyperechoic than the renal cortex. So echotexture, in contrast, is about how homogeneous or heterogeneous the organ is, and it should be reasonably homogeneous, but we should be able to see those portal veins and hepatic veins throughout the liver. So we need to be careful not to confuse machine settings. So if you're adjusting your overall gain a lot, then you might confuse differences between organs, brightness, whereas it is actually the machine buttons you're changing. You're comparing the organs, so I like the saying, my cat loves sunny places, medulla, cortex, liver, spleen, prostate. That's in the order of going from hypoechoic to hyperechoic. That's the order that they should be. Prostate there, we're talking about entire males really. So how homogeneous they are, so looking at the echotexture, we're looking for those visible portal and hepatic veins. And think about adjusting your overall gain and time gain compensation and then judging the tissue differences. So top tip is in a normal liver, you should expect to see portal veins with bright hyperechoic walls and hepatic veins as round anechoic holes within the parenchyma. Bile ducts are not usually visible, though in cats they may occasionally be seen, and the key is a uniform background echotexture with normal vascular landmarks standing out really clearly. So let's take a look at some cases where we can see some changes in echogenicity and echotexture. So here we've got quite a hypoechoic liver. There is a number of things that can cause this, and you really need a sample, ideally a biopsy, to work that up further. Cases where you might have a hyperechoic liver, you're more thinking about hepatic lipidosis, steroid hepatopathy. The list is shorter, but for hypoechoic livers, the portal veins will stand out really clearly. Here we've got a really heterogeneous liver where we've got some hyperechoic areas and some anechoic regions as well, so really heterogeneous there. Again, here we've got quite a hyperechoic liver. We can't really see the portal vein walls very well, and we've got some nodules, so quite a heterogeneous appearance here. This, again, quite a heterogeneous appearance with this liver tumour or potentially abscess in this region here. This is actually the gallbladder up here, and this was a separate structure within the liver in this case. Moving on to our second E, which is edge. So the edge of the liver should appear smooth, continuous, clear, well-defined edges are expected. If we've got any irregularities, any nodules, poorly defined margins, this could signal underlying disease or perihepatic changes and should always be noted. So we're expecting that smooth capsule, no nodules, and looking at the surroundings also. So top tip, between the liver and the diaphragm is a common place for free fluid to collect. Always scan to the most cranial point to check for subtle effusions that can otherwise be missed. So here's an example of that sort of free fluid pocket where we have the liver here. Here's a nice portal vein, here's a nice portal vein, here's a hepatic vein. We can see that bright white diaphragm along here. This is one of these points where I talked about refraction, making it look like there's a hole in the diaphragm when there in fact isn't. But here we've got some free fluid collecting between the liver and the diaphragm. And this is an important point to note. Often people will cut off the liver here and only see this section, but you need to rock the probe, check back in that how to scan video, so you rock and really get that cranial portion of the liver included there. Moving on to the D, that stands for distribution and dynamics, and we'll start with distribution. So in a normal liver, the parenchyma should look the same throughout, with no focal or multifocal changes. The portal vasculature should be visible and regularly spaced, and describing the normal distribution confirms that you've checked the whole organ, not just a single window. So we're looking for that uniform parenchyma, no focal or multifocal changes, portal and hepatic vessels seen, evenly distributed, and that you've checked the whole organ. So my top tip is to fan slowly through the liver in 2 planes to assess the entire parenchyma. Don't stop when you see one normal or abnormal area. Focal changes can be missed if you do not cover the whole organ. So here we have an example of some multifocal changes in our liver. So we've got a transverse view here where we've got our diaphragm quite horizontal and we're fanning all the way through. We can see there are some nodules, one large one up here at the beginning of the video, the cine loop here. We have the gallbladder down here and we can see the vessels as well on our image. The liver itself is potentially hyperechoic in this case, but there are certainly some multifocal hypoechoic changes. So once you have found a focal or a multifocal area that's different in the liver, it's really important to describe that, and we just repeat using speed. So when it comes to these lesions that we've seen in our previous video here, we measure it. So thinking about the size, height, width, depth. So we really need to get 3 planes to understand, or 2 planes, 3 measurements to understand how big this lesion is. That measurement is really key because if you don't do any further treatment, a potential monitoring technique will be to see if that changes in size, but we really need to have monitored and written down that measurement. Thinking about the shape of the lesion, again, we need to scan through that lesion in 2 planes. The position of it, was it on the right side of the liver, the left side of the liver, associated with the gallbladder, etc., etc. The echogenicity, we are an echotexture with, in this case, thinking about that it's quite hypoechoic compared to the rest of the liver, but it's quite homogeneous in itself. The edge, is it poorly defined, well defined? Does it have an irregular edge, a regular edge? Those are all things to describe there. Dynamics is a really key one. So thinking about the blood flow in the lesion. So here we've put power Doppler on to try and assess whether there's any blood vessels, and we can see one entering here. And then the final S here is for sampling. So it's really important to know this is a handy tool. Ultrasound-guided sampling can really get us to our definitive diagnosis. And it's important to know whether you think that that is potentially possible. There's no big blood vessels in the way, there's no other organs you have to go through, the distance is reasonable for a needle to extend to, etc. So observing all those different things with this lesion should be noted as well. So you sort of go through a mini speeds when you've got something under that distribution. Next we have dynamics. So when you're thinking about dynamics in the liver, we're really thinking about blood flow and bile. So how are these flowing through the organ? Normal findings will be those smooth portal veins with their hyperechoic walls, and then unobstructed drainage by the caudal vena cava, hepatic veins, no visible bile duct dilation. So any abnormal dynamics there might suggest vascular anomalies such as portosystemic shunts or potentially biliary obstruction. So think about your portal vein flow. Is it normal laminar flow? Is there any turbulence anywhere? And our venous outflow, caudal vena cava and hepatic veins. Our biliary drainage, there should be no bile duct obstruction or dilatation. So my top tip here is to first assess blood flow, follow the portal vein as it enters the liver, and check the caudal vena cava and hepatic veins at the diaphragm. So any abnormal direction of flow or turbulence might suggest a shunt or an obstruction. Also assess bile flow. Ducts should not be dilated in a normal liver, although in cats, small ducts might occasionally be seen, and they can be quite tortuous as well. Dilation or irregularity raises suspicion for obstruction. So do not be afraid to use that colour flow mapping tool on your machines to try and look at the blood flow. This is some nice normal blood flow through the liver, where we can see red is going towards the probe and blue is going away from the probe. Our final S stands for sampling. Now I want you to consider sampling even if you're not at the stage of being able to sample yet, or not feeling confident enough to sample yet. I want you to consider whether it is possible in this case, or whether it is a good next step for this case. So often ultrasound is brilliant at finding pathology, but not at differentiating it. So we often need those cells to really get to our differential diagnosis. Ultrasound can absolutely help us with that, but it's an additional thing to think about. So sampling is not required when the liver appears normal, but it's important to document whether it was considered or performed. So in cases of pathology, sampling might involve fine needle aspirates, biopsies, bile aspirates, depending on risks and clinical indications. And we always need to weigh diagnostic value against the risk of hemorrhage or seeding. So normal liver, no sampling needed, but record that. Pathology present, consider FNA, biopsy, prostatic washes, traumatic catheterizations, all ultrasound guided. Really consider all of those potentials. Assess your risk, so the bleeding risk, coagulation status, but also are there any big blood vessels nearby, patient stability, and access to a lesion. So a top tip for your normal liver, state clearly that no sampling was performed, and when sampling is indicated, ultrasound guidance really helps to target the lesions, safely avoiding other organs and vessels. Always balance diagnostic value against risk, especially with vascular lesions or when clotting status is uncertain. So here we have a video of me taking a fine needle aspirate from the liver. So we can see our needle tip coming in here. I'm using the woodpecker technique. I'm not aspirating and I'm avoiding any other large vessels, etc. before withdrawing the needle and putting that on a slide and sending that off for histology. So don't be afraid to, even if you're not going to go ahead with fine needle aspirate, really consider would it be safe in this patient, and would it be beneficial for this patient? Start thinking along those lines. So if you've ever second-guessed yourself after a scan, you now know there's a better way forward. Speeds gives you the structure to stop feeling vague, stop doubting yourself, and start writing reports you can stand behind with confidence. And this was just a taste of what we're working on inside the FOVU Club. If you'd like structured training, real first opinion cases, updates on pathology, and feedback on your own scans, then I'd love to see you in there. To get started today, download the free FOVU SPEEDS reporting guide. It gives you prompts for every abdominal organ so you can put speeds into action straight away. The link is below this video. Your scan might be silent, but your report shouldn't be. Let speed speak for your thinking.